This is actually a human skull, and you can see the styloids are just enormous. They go all the way down to the axis, or C2. If you look at this one, the normal styloid is very, very small, maybe 1 centimeter. And then the styloid bone is never supposed to grow or elongate to get down to the atlas at C1. It's never supposed to get down to the atlas because it's going to narrow the space. The bone typically is going to grow in a manner that's going to obstruct the space where the glossopharyngeal nerve goes, the vagus nerve goes, and of course the jugular vein. We look at all these things in the office. So we do cone beam CT scans. So you can see right here where this person's styloid is going way past the atlas. And I put this particular person's other views in there. So if you look at this carefully, this is the occiput. This is C1. See how far forward C1 is in relationship to the occipital condyle. It's like almost 7 millimeters. So I know that with proper curve correction, with stabilization of the occipital atlanto ligaments, or atlanto-occipital, depending on the nomenclature you use, of their capsular ligaments. In other words, tightening of these capsular ligaments should increase the space between the styloid and the atlas by 7 millimeters. Now that's significant when you're trying to figure out, does the person need the styloid out or not? So when you have an elongated styloid, the danger is what? You're getting compression of the jugular vein because of the instabilities in your neck, because of the malrotations, because your atlas is too far forward, but now you have a bony bridge in the front. You have a bony bridge in the front. So some people, the bony bridge is so significant, you just have to get the bony bridge out. So that's why I just wanted to, go through what happens with a styloidectomy from my perspective, and what have my patients said, the ones who I've sent for styloidectomy, have they gotten better, have they not gotten better? Now, you might say, well, geez, I thought an elongated styloid was rare, so this is just my opinion of it. If you research Google and you type in Eagle syndrome, elongated styloid, you'll find that almost all the articles say elongated styloid's rare, elongated styloid's rare, but you got to realize almost all the articles were written before the year 2000. Well, Steve Jobs didn't have the iPhone until like the year 2000. So since the year 2000, the explosion of cell phones has just been crazy. So for the first time in human history, everybody's like this. Everybody's like this with the jaw forward. Well, there's 2 ligaments that attach to the styloid bone. One is the stylomandibular ligament. The other one's the stylohyoid ligament. So the stylohyoid ligament, that helps stabilize the hyoid bone. The hyoid bone is what the tongue muscles rest on. The one that's really causing the problem, in my opinion, is the stylomandibular ligaments. Many, many people have clicking, popping, grinding in the TMJ, or their jaw is always forward. One of the ligaments that has increased tension because of TMJ to try to stabilize the mandible, and that's under tension because of the jaws forward, is the stylomandibular ligament. When the stylomandibular ligament is under tension, that ligament can become calcified, and the calcification of that ligament is called an elongated styloid. Oh, I should say, so the calcification from the stylomandibular ligament is going to be here, and you see the hyoid bone. So when the stylohyoid ligament gets calcified, it's normally down here, not up there. And then this was a patient of ours where you could see where they have an elongated styloid here, which is from the stylomandibular ligament, and this is the calcification from the stylohyoid ligament. When to suspect you have an elongated styloid causing symptoms versus cervical destructure or instability? When you lay down on your back and this increases symptoms. Elongated styloid, yes. Cervical destructure, no. So when a person lays down, so say they have an elongated styloid, when they lay down and they have pillows, it's going to cause flexion of the head. So when you have flexion of the head, that's going to cause the styloid to go in the jugular vein, which occurs when you're sleeping. So the person who has that should do what? They should sleep on their side and look at the back wall. So instead of having pillows and go like that, the person should lay on their bed and either have something underneath their neck, so they're causing their jaw to go forward, or they lay on their side and then they look up at the back wall. So if that significantly helps you, like you have less head pressure, you have less anxiety, it's probably that you have a styloid that was causing obstruction of the jugular vein. So sleeping on the side with the chin tuck increases symptoms. That's an elongated styloid. If you put your chin out, that decreases symptoms. So that I'm just talking about when you're laying down. So if a person's laying down and they have something underneath their neck, it's going to cause the head to go back. That gives it more space here. Or if they're laying on their side and they go like that. Exercises for neck posture increase symptoms, yes. So if you've had a physical therapist or a chiropractor say, duck your chin in, and it gets you dizzy and you feel worse, well, you probably have an elongated styloid, like you're ducking your chin in, you're ducking your chin in, you're ducking your chin in. And that can not just compress the jugular vein, but it can injure the vagus nerve. So a list of patient symptoms that have been resolved or improved after a styloidectomy. So this was actually an email that the office got, one of my staff got, and the patient said after their styloidectomy, their constant severe headaches were reduced to now and then. The fluid mass in front of their Adam's apple was gone. So you might say, well, what's that? Well, once the jugular vein can drain, the fluid from the brain doesn't have to drain through the lymph system. So some people have enlarged lymph nodes in their neck, which is just from compression of their jugular veins, and the fluid goes into their lymph nodes. The light sensitivity got better. The neck has reduced in size because there's not all kinds of swelling here, because now the fluid flow is going through the normal tracts, which is the jugular vein. Their oscillopsia, that unstable gaze, has gotten better. Their sense of direction is returning. Severe brain fog's better, tinnitus, vertigo, and the snowy sensation or pixelation. The vision is like little pixels. That has gotten way, way better. Why? Because the brain pressure went down. Brain pressure goes down, eye pressure goes down, fluid flow into the eye gets better, the pressure on the optic nerve gets better, and everything gets better. And this was what they sent us. So that's like what a styloid looks like when it's removed. The operation from the doctors, the styloid doctors that I talked to, is about a 2.5-hour operation. Most doctors just do one side. Occasionally there's doctors who do both sides at once. And then that's what the incision looks like. That was a picture from a patient of ours. And then, so I'm just going to show, I could show lots of scans before and after. So I'm going to explain why some people need prolotherapy and curve correction and care after a styloidectomy. So this particular patient, if you look at it, the right jugular vein, the compression of it didn't change all that much. So this was a patient who I said to them, to get you completely better or the resolution of most of your symptoms, you're probably going to need styloidectomy plus our care, prolotherapy, curve correction. So this particular person on this side, the atlas was still compressing it. And then on the other side, there was, it was open more. It was completely compressed before the styloidectomy, and after, on the left internal jugular vein, it's way, way more open. This was in the upright position. And again, this is just pre and post. So this person has a big styloid there in the atlas, and then the styloid's gone, obviously, there. And then pre-styloid, you could see the styloid here, and then over here, there's obviously no styloid. Then this is what an enlarged styloid looks like on digital motion X-ray, but most of the time we're documenting it by cone beam CT scan. How you diagnose that a styloid's causing a problem or the atlas is causing a problem is by CT venogram, or in our office we do ultrasounds of the jugular veins in different positions. So this just shows where the atlas is compressing the jugular vein. That's the styloid. So in this particular patient, it's the atlas that's compressing it. And then this is what it looks like on CT venogram. You could see, right, where the jugular vein's getting compressed there by an elongated styloid. This was told to me by one of the great styloid doctors in the country, and he said when the person has stability in the neck, they have a decent neck curve, you know, styloidectomy, when styloid is causing compression of the jugular vein, I mean, it's like remarkable. It's, you know, 80+% of the symptoms or 100% of the symptoms go away. When they have just a little bit of problem in the neck, like a little bit of well, they have a straight curve, they might have a little bit of instability, the styloidectomy gets rid of 50%. When you have a lot of cervical instability and a horrible curve, the styloidectomy is only going to get 20% of the symptoms resolved. I guess the take-home point is people who believe that they might have a styloid causing the problem either need to get a cone beam CT scan or a CT scan that involves the neck, preferably a venogram, or you go to a clinic like ours where we do jugular vein diameter studies in different positions. Then it's also good to do an analysis, some kind of analysis, such as a digital motion X-ray or motion X-ray or motion MRI to document cervical instability and where the neck curve is. And after that, you should be able to figure out what category the person's going to be here. So in our office, when we do in the neutral position, when we do a cone beam CT scan, if the styloid is basically on the atlas, well, first of all, the styloid should not go down to the atlas, but we like to see at least 7 millimeters of space because the jugular vein is normally 9 to 10 millimeters in diameter. So as long as there's 7 millimeters of space, you know, the blood flow into and out of the brain should be okay. But when there's no space, like the styloids are hitting the atlas, often those patients are going to end up needing a styloidectomy to get resolution of their symptoms.